Just in the interest of time, I'm going to move us quickly forward because we're a little bit behind from the last session. So this is about Impella setup and ICU management. We'll show you the setup of the controller in just a few minutes. I think everyone is generally speaking familiar with the idea that we place the 14 French sheath into the right common femoral or left common femoral artery, or more recently in the axillary artery, cross the LV aortic valve with a pigtail, place the pigtail into the LV, place an 025 platinum plus wire into the LV so that it drapes the apex, and then along that you place the Impella and you either treat your shock or do your PCI. But then what, right? How do you manage the patient who requires the device in the ICU? These are my disclosures. So the best ICU management starts in the cath lab. The number one reason for headaches with Impella work is hemostasis issues, specifically is bleeding in the ICU or limb ischemia in the ICU. Advance the repositioning sheath once you peel away the sheath, the 14 French placement sheath, completely out of the femoral. Once you advance the repositioning sheath with tapers from 13 French down to 9 French, you fasten that sheath in place, and when you take your sutures to fasten that sheath in place, you cranialize them. So you suture high up on the femoral trigone so that it pulls on the Impella repositioning sheath and actually pulls the device in towards the femoral. That helps to reduce bleeding. In addition, when you pre-close these patients, you can tighten the long suture of the perclose so that it cinches the artery down around the repositioning sheath, which reduces from 13 French to 9 French as you go further and further down into the body. And then, of course, you securely tighten the TUI Borst adapter to suture to ensure the device doesn't move when you suture the wings of the repositioning sheath to the skin. So the question is then, if you've got pre-closure sutures in and you need to leave the device in, is it safe to take the device to the ICU and leave it there for 3 days with pre-closure sutures hanging out? And if you do, how do you store those? This is actually a studied technique called a delayed closure. And this is what I typically do at my institution. So these, you may recognize these little orange tubes. These are the tubes that our surgical colleagues use to suspend their pericardial sutures when they suspend the pericardium. So I cut them in half. You take the long perclose suture of the perclose and you pull it into this tourniquet. These are made by Medtronic. They're easy to get. They come in packages of 6. So once you pull, and on this one you'll see that, once you pull the long suture into the tourniquet, what you can do once the suture goes through it is thread the tourniquet down along both perclose sutures. Pull the sutures through the tourniquet so that they're covered, and then pulling just the long suture, so not the locking suture, you push down on the tourniquet so you actually create some tension and then lock that suture along the tourniquet. And you're able to then lock it here and then turn the suture around the little dial on the end of the tourniquet, which locks it in place. And what you end up getting is a very nice secure coverage of your perclose suture. You do have to keep it moist because they do get brittle over time. And you end up with a configuration that looks like this at the level of the femoral, where what you have are these 2 tourniquets covering both of your pre-closure sutures. You have to remember which one's your first and which one's your second. You can label them 1 and 2 with stickers if you want. And then these are protected so that when you take the patient to the ICU, even if you have to close them 2 or 3 days later, you can do that without much difficulty after pulling the suture out of the tourniquets and then cinching down the perclose that you had previously implanted. And this has been studied reasonably well by our colleagues in Detroit. At the time, they used to clip the sutures and wrap them into betadine impregnated gauze, but this tourniquet solution is a lot easier. The most important bit is that when you're going to close them in the ICU after a couple of days, you do have to betadine clean the entire surface to make sure those sutures are completely clean when you're tapping down the knot so you don't end up with an endovasculitis. So that's how you manage bleeding, and that's how you manage position. So let's now take this patient from the ICU, and the Impella arrives in the CCU. From the cath lab, the Impella arrives in the CCU, and this is what you have on your console. With an Impella CP Smart Assist only flowing 1.4 liters at P8, with this placement tracing and this motor current. Does this look normal or abnormal? Is generally speaking the first question that people will ask themselves. I'll tell you now, this is a very abnormal tracing. When we analyze in AIC, and the most important piece here is do not be afraid of this. This is your friend. It gives you a ton of information on what's going on. There are 4 major components of information to this that you can use when you're managing these patients in the ICU. The placement signal, this is generally speaking an art line signal. It's the pressure difference between the 2 ports on the device. So if you have an aortic waveform, you're in the right place because what it's measuring is outside the aortic valve. But if your waveform is not an aortic waveform, you have to ask yourself where the top of that device is actually sitting. This is the motor current. The motor current is a measure of the actual energy the motor is using to move. So if, for example, you have a device that is contracting in systole and diastole, remembering that this pump is taking blood from the same chamber as is exiting, if the motor is moving, it's going to move a little bit less during systole because the heart's doing some work, and a little bit more during diastole because the heart is not doing much work. And so if you have good variability along the motor current, your device is functioning normally. If your motor current, however, is flat, then you have to ask yourself why the pump is not requiring more energy in each phase of the cardiac cycle. The pump flow tells you how much you're venting per minute in liters per minute. This is not the algebraic sum, this flow plus the right heart cath, to determine your total cardiac output. It's not an algebraic sum because ultimately the pump and the heart are both pumping the same blood. And your P level, your flow control, tells you approximately where on the Impella scale of flow you are, where higher P rates mean the device is functioning with higher flows and lower P rates mean the device is functioning with lower flows. So that in a nutshell is what you're looking at on an AIC. So this patient now has these hemodynamics. Your blood pressure is 73 on 40, your heart rate is 108. This is terrible, right? So what's the problem? Well, we have an approach to AIC analysis. The first thing you look at is the placement signal because much of the time it can tell you the problem. And the question we ask ourselves is, does this look like an aortic waveform? It does not, right? It looks much more like an LV waveform. And so if it looks like an LV waveform, where is the device? It's deep, right? The entire device is skated into the LV, and what you've got is an entire device sitting in the left ventricle with very little to no hemodynamic support being offered because the outflow of the device is below the aortic valve. And all you had to do was look at the AIC to tell you that. So position issues are the most frequent problem in the ICU. Okay, stable positions that don't migrate are difficult to achieve with CP devices at the beginning. And as a result, it's very, very important that when you leave the cath lab, your device is where you want it to be, and that you check the position on echo the moment you run into the ICU. That should be part of your regular and standard protocol. This is where the device should sit in a normal patient. Your inflow cage, so the mosaic below the aortic valve, should be approximately 3.5 centimeters from the aortic valve. You best are able to assess this in a parasternal long axis view. If it's at 3.8 and you're getting good flow with no hemolysis and no suction alarms, no flow alarms, your flows are good, don't touch it. It's like waking a child in the middle of the night to eat. It's just a silly thing to do because it's functioning completely normally. But these are the guidelines on where you want to be. So let's look at this. Where is this? Does this look normal to you? Well, this is the AIC that we just discussed, right? So this device is clearly in the LV. And then after attempted repositioning, you get this. So this is the other major problem in the ICU, is hemolysis. Hemolysis happens with every VAD eventually. But with percutaneous VADs like the Impella, the most important piece is recognizing hemolysis as a result of position issues. Whenever the device skates in too deep or comes back too far or gets entangled in the mitral valve, you put yourself at risk for hemolysis. The problem ends up being where the outflow cage throws red blood cells out at the aortic valve, or the inflow cage is sucking red blood cells in when adjacent to another structure. At those points, red blood cells will then get torn apart and you end up getting hemolysis. And so 95% of the time early on when you're getting hemolysis, it's a position issue and you sit there and you simply reposition it using echo guidance in real time. You never let the sun set on hemolysis, never. It has to be resolved, otherwise you will lose your kidneys. So this is a correct position where you've got the mosaic from your outflow cage above the aortic valve and the mosaic from your inflow cage, which is not shown here, below your aortic valve. This is an incorrect position where your mosaic is in fact at the level of the aortic valve and you're tearing up red blood cells. From an anticoagulation piece, you aim to maintain between 160 and 180 ACTs. That's usually a PTT of about 60. And if you suspect HIT, verify it because it's a rare problem. And if you have a problem where you have to pull the heparin, you can use sodium bicarbonate as your purge. You do not need to put them on systemic heparin in those situations, as long as the device is functioning at a level of P6 or higher. And then other important pieces are making sure that you have a calibrated art line, because the placement signal, though it gives you a blood pressure, is useful. It is a non-zeroed art line. And then develop a daily protocol to supervise the device when it's in the unit. Every day you do an echo, every day you get hemolysis labs, every day you check the position, both on the device at the leg as well as within the heart. And then here's the other piece to optimal ICU management. Don't do this, right? We don't use levofed, we don't use vasopressin, we don't use dobutamine without an arterial line, because we need to understand what we're modifying. Here, you need hemodynamics in order to be able to modify the function of a hemodynamic support device. It's shocking how many people have been afraid of doing that, but still being willing to use the therapy. It just doesn't make a whole lot of sense. So, with the hemodynamics, you're able to augment your analysis of the AIC. So let's look at this for a moment, okay? Here, let's develop an approach to analyzing the AIC in the ICU. The first thing you look at, as I said, was the placement signal. Does this look like an aortic waveform? It does, right? What about your motor current? Do we have variability in the motor current? i.e., is this motor doing different things in systole and diastole? Is it speeding up and slowing down normally? The answer is no. But you have a high flow rate and you have a high flow control. So then the next thing you do is look at the echo, and you see that the device is in the aorta, which is why there's no differences between systole and diastole on your motor current. Okay? How about this case? Now you have a placement signal that looks aortic with good variability, but slow flows, right? Despite a high P level. So here you look at the placement signal, it looks appropriate. Is there variability in the motor current? Yes. Then step 3 is you always look at your hemodynamics. So now when we look at the hemodynamics, we see same blood pressures, but now your CVP is 3. So what's the problem? This is a device that will suction when you're dry. And as a result, in this case, you have a suction alarm, where because you are either bleeding or you're too dry or you're vasodilated, the device cannot generate the flows that it's supposed to. And that is why your placement signal shows a low pressure. It's because you're not getting effective hemodynamic support. And this is the differential associated with that problem. So the process is placement signal, motor current, flow rate, hemodynamics, back to the AIC. That's the approach. And it's the approach every single time, over and over again. Now with the CP Smart Assist, you can use the LV waveform and you get this type of a picture. This is what's called a diastolic suction event. It's an early marker of low volume states, either bleeding, RV failure, or vasodilation, or overall volume depletion. And how about this case now? Same approach. Is the placement signal reasonable? Does it look like it should? Yes, it looks like an aortic signal. Does the motor current look like it should? Well, there isn't a ton of variability here, right? So that means that the device is doing as much work in systole, almost as much as it is, or as much work in diastole, almost as much as it is in systole. So the question you have to ask yourself is, why is this device functioning at full output in both cycles? Especially when it's giving me pretty good flow. Well, if the device is maximally functioning and giving you good flow, but you have a low blood pressure, what you have to ask yourself is, are the hemodynamics suggestive of reasonable volume? They are. Are they suggestive of poor blood pressure and poor pulsatility? They are. So this is one of those situations where the device is doing what it should. The problem is the heart's not working, right? So you have low intrinsic pulsatility. And this is when you may actually need to escalate the device to a 5.5, or in India right now a 5.0, eventually to a 5.5, or escalate to another form of hemodynamic support. What about this one? So does this look like an aortic waveform? Sure, right? Placement signal, motor current. Does this look like a normal motor current? It's not the normal straight up and down, is it? It comes into this crest, but then when it comes into a peak, so where it should be at peak output, you get cresting, you get a flattening of this curve. So why would the motor current, why would the device run into a resistance issue and it's flowing at maximum. Well, if you look at your systolic pressure here, you see that it's actually pretty high and your flow rates are pretty low. So then you look at your hemodynamics one more time and you confirm that in fact your diastolic pressure is sky high. So what's the problem here? The problem is way too much afterload. The problem is that you have the patient on a ridiculous dose of levofed and an axial flow pump, which pumps forward from the LV out into the aorta, cannot pump against very high afterload. And so the problem here is that either you have too much vasopressor on board or you may need to escalate your therapy because your current hemodynamic support paradigm isn't enough to support the patient's needs. And then as far as weaning goes, this is the Smart Assist platform, and this is how you can use it for weaning. It gives you a snapshot of anywhere between a minute to 10 minutes of data, where you can look at your map, you can look at your LV EDP, and it's important to do a right heart cath when on support so you can put in the required numbers for the fiber optic sensor to be able to give you this information. And then you follow the total cardiac output. And when you're ready to wean, which is when you're off inotropes or on a very small dose of one inotrope, when your hemodynamics are compensated, when your patient's doing well, okay, when the lactates are normal, you don't wean before the lactate's normal, that wouldn't make any sense. At that point, you start to reduce your Impella flows. And as your Impella flow goes down, your native cardiac output should go up. Not stay the same, go up. If it's not going up, it's a wean failure and you're not ready. If it is going up, then you continue to wean every 2 hours, at least that's the protocol at our institution, and when you get down to P4, you're usually able to wean fairly quickly onto P2 and 0. So that's the management of this device in the ICU. That's how you start to think through addressing the usual features that come up in the ICU, and that's a way to reduce the fear of taking the device into the ICU. You need to know about bleeding, you need to know about hemolysis, you need to know about making sure you're in the right position, and you need to be able to analyze alarms from your AIC. So, speaking of which, we'll take you over to the AIC for a quick second here, just to be able to show you how to set the device up. This is the Impella catheter, okay? There are two segments to this catheter. There's the inflow cage here. This is what sits inside the LV. So if we can get a camera to just come in closely on my hands. This end sits inside the LV. This end throws blood out into the aorta. And as a result, the device, if you were sitting in my heart, would be sitting like this, right? With the pigtail towards the apex, the inflow cage within the heart, the outflow cage within the aorta, okay? Now, how do you set this thing up within the AIC just before you implant? Well, here's how. First, you press this little button on the side and you release the door that covers the cartridge, which is going to be your purge, okay? You click on Start New Case. And so the first thing you do is spike the dextrose bag. That's going to be part of your purge solution. It creates the hydraulic barrier within the device to ensure there's no blood that gets in the motor. Once you've spiked the dextrose bag, you press Next, which makes life pretty easy. The next thing it tells you to do is insert the purge cassette. So you do this with the Abiomed label on the outside. There's only one way to fit it in. Once you fit that in, you take the second segment and you fit it into this slot, okay? And pull it, there you can just fit that, and just push it in until it clicks. That's exactly what it tells you to do here. Okay, and now it starts to prime the system. The next thing you do is take the catheter plug, you lift this gray door and you place the catheter plug into the device. Once you're plugged in, it starts purging the device. You hook up the purge cassette to the back, okay? As soon as the purge cassette is primed, you hook it up to the back of the device. It will then purge the device and you're ready to implant. It's that simple. It's a pretty straightforward approach. Most of the time, the nursing staff or your staff in the cath lab will be able to set this up for you. It's pictorially described, and it's just step by step, one step after the other. And once you're primed and ready to go, and here you are, in this situation, you're ready to go, you press Accept. It'll give you the various settings that you have. It'll prime the Impella, and then by this time, as operators, we're putting the pigtail across, making sure that we've given heparin to an implantation ACT of over 250 seconds. 260 seconds, and then we place this onto the placement wire that is sitting in the LV, put it into the 14 French peel-away sheath, and up it goes. Once you're in, you remove the wire completely. And generally speaking, I instruct the people in the lab to double check that the wire is out. So you say, is the wire, the staff in the lab should say, is the wire completely removed? The answer should be yes. Then you push start Impella. And once you start the Impella, and we'll put it into the water here so you can see what it does. Okay? Okay? It says, is the Impella catheter inserted in the patient? You click on yes, and then it will start to function. I'm just going to turn the flow control down before it gets too high. Okay? So these buttons on the device are the way you actually adjust flow control. Flow control is marked by a button called flow control. Okay? So you press the flow control button if you need to turn it up, and you turn this knob to select the P level that you want, and you press the knob in, and you'll see that the amount of flow that the device provides starts to go up. Generally speaking, in high-risk PCI, we'll leave it on P9, or we'll leave it on auto, and then when it comes down back into the ICU, you'll end up leaving it on P9 for most of the time. Last bit is when you look at the display, there are a variety of displays you can look at. The one that's going to be most important to you is the one that says LV/EDP/CO trend. That is how you bring up your Smart Assist screen, and how you can see where your cardiac output is going, where your machine output is going, and how to wean the patient. That's about it. It's a pretty simple device to use. The key is having an approach to managing it when you're in the ICU, and that approach is always the same. Cultivate a position check every day, ensure that you check the urine every day, check your hemolysis labs every day, make sure the position's checked on echo every day, and just monitor your AIC and your hemodynamics. Thanks very much.